Hello everyone. Today I will present our study of robotic pancreaticoduodenectomy with vascular resection for pancreatic ductal adenocarcinoma. I'm Dr. Jin from Beijing Hospital. Our center is a high-volume center performing more than 1,000 pancreatictomy in recent 3 years, including more than 75% malignancy, and one-third of this resection underwent robotic assistance. Our previous study has showed that the DFS and OS were compatible between patients receiving robotic pancreaticoduodenectomy and open pancreaticoduodenectomy. This study still requires further confirmation with prospective randomized controlled trials, but for now we don't have it yet in the world. So our study enrolled 976 patients scheduled to undergo pancreaticoduodenectomy between August 2011 to April 2019. We had 136 patients planned for PD with vascular resection. After the exclusion criteria selection, finally we have 84 patients in this study, including 40 undergo robotic pancreaticoduodenectomy and 70 open approach. The result is that 2 cases in the robotic group were converted to open surgery. In both groups, more than 60% of cases involved end-to-end anastomosis of portal mesenteric venous reconstructions. In the intention to treat analysis, surgical outcomes, including median estimated blood loss, operative time, and post-operative stay, were compatible. The major post-operative complications, including classification C pancreatic fistula, were also compatible. The robotic group had fewer harvest lymph nodes, which is 14 in robotic group and 16 in open group. The two groups had similar curative resection rates, and 3-year survival rates were compatible. As you can see, the DFS and OS were compatible in these two groups. Regarding the other reports from the world, our data is also compatible here and acceptable. The limitation is that these patients still had poor prognosis, and yes, we didn't give neoadjuvant chemotherapy for these patients. Our conclusion is robotic pancreaticoduodenectomy with vascular resection appears to be safe and feasible when utilized in high-volume centers for highly selected PDAC with similar morbidity, mortality, and acceptable survival outcomes. Further prospective randomized studies are needed to assess the feasibility of this approach. Thank you for your attention.